You sounded like Fee. And I'll get a pool suction tip, please.
Yes, sir.
Yeah. Hi, guys. This is Charles. I'm one of the surgeons at the Animal Emergency Centre in Melbourne, Australia. Today we have a really interesting case, which is an older cat that presented with maybe just a little bit of weight loss, and the referring vet incidentally picked up a large abdominal mass. And they did an ultrasound and found a really big mass that was associated or in close proximity to the vena cava, pushing the vena cava ventrally. So it's dorsal to the vena cava and also attached to the right adrenal gland and is displacing that right adrenal gland medially as well. We're going to go in and try to remove it. My guess is that it's probably a mental infarct, which is a benign growth. They did an aspirate on it and found that there was evidence of necrosis and no evidence of neoplasia. And so that's the working diagnosis. And since it is causing weight loss in the cat, maybe a little bit of lethargy, we've recommended surgical removal. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. Can I please get our extra large, super large Gelpies?
I got them right here.
Thank you. So instead of using Balfour retractors, we are using big Gelpies. And so this should be interesting. Now the risks associated with this surgery, big one that I'm concerned about is blood loss, because it is attached to the vena cava. And so I will have to be very careful, and my plan is either to peel it off the vena cava or to open it up, remove as much as I can, and then omentalize it. Because if it is an omental infarct, it's full of just cystic and necrotic material, then omentalizing it also should resolve the problem. So hope you're as excited as I am. I got quizzed by one of the owner's friends on the phone about how rested I feel today. And I just got off a long weekend, so I'm feeling very rested. So had a question, why is this high risk? And it's because the mass is adhered or attached to the vena cava. So I'm just going through the linea alba right here. Tent that up a little bit. So in the abdomen there, let me just stop that bleeding there. So that's falciform ligament there, or falciform fat. Cynthia is away on holiday with family. And so I have Aaron, my senior nurse, scrubbed in with me. You can see the liver. The liver looks surprisingly healthy for a 14-year-old cat. And my eyes aren't microscopes. Subjectively, it still looks pretty good. I may have to get my loops at some point during the surgery.
Porter, are you alright, or do you need it turned up?
No, it's good.
No, it's good.
So the cautery is not as effective as it might be because fat doesn't conduct electricity very well. So what you find is that on soft tissue, it works really well, and in the falciform fat, it doesn't work well at all. Now this cat came with a CT scan having been done already. Certainly makes my life easier. There's a great CT-only practice here in Melbourne. All they do is CT scans, outpatient CT scans. So, all right, so this mouse is sitting right here, and that's the vena cava sitting on top of it. Can I please get ligashore? All right, so that's the vena cava sitting right on top of that mass. And there's a question, can you spare the adrenal gland? Yes, you can remove one adrenal gland. In fact, you can remove both adrenal glands. It's just that they become Addisonian, and then you have to manage them as an Addisonian patient with supplementation. And there are some internal medicine specialists that actually advocate for making pituitary-dependent Cushingoid dogs Addisonian by removing both adrenal glands, and thinking that it's actually safer and easier to manage. Yeah. It's easier and safer to manage an Addisonian patient. I might have you retract on that. So if you look closely, you can actually see the blood flowing through the vena cava right there. So get some idea. Can I get a little needle probe, please? All right, so I'm going to zoom my camera in. All right, so if you look closely at that vena cava, you can see the blood flowing through it right there. Okay. All right, so the trick is going to be to decide how I'm going to peel this thing off. I've got a kidney right there. Yeah, that's it. Yeah. All right, so the trick is going to be, can we get some saline, please? Oh, we need probably more than that. Or is that already moistened? Oh, great. Thank you. I should be okay with the saline that we have. Thank you. So I've just got a little needle probe now. That's my needle probe there, and I'm just going to put a little hook in the end of it, like that. And that just makes it a little easier for me to dissect tissues off the vena cava. You know what? Let me go ahead and get my loops, please. Thank you. They might be in my office. Yeah. All right, so I'm just taking off that's the caudate lobe of the liver. And this is retroperitoneum here. All right, so before I get too far into it, I'm going to get my loops on. I'm going right up against the vena cava there. And again, if I'm concerned about the attachment of the mass to the vena cava, I'm just going to open it up and omentalize it. Sorry, just getting my loops on right now. Feel a little bit funny. Yep. Okay, so that's liver up there, that's caudate lobe of the liver there, that's also a little bit adhered to the vena cava. I predicted a mortality rate of about 2% here with this cat. Hopefully we'll get through it. What I like about the needle probe is that I can poke it through, identify what I want to cauterize, and then activate the cautery so that I'm not right on the vena cava when I'm cauterizing. So I see the left renal vein coming out back here. Okay, so I'm peeling that off the vena cava now. Can I get cautery turned down, please, to 20/20? Or is it already? Let's do 15/15, please.
Yes, sir.
Thank you. So that's the right renal vein back there. So I'm basically just trying to skeletonize the venous supply. It's a bit tightly adhered. Kind of scary when you can actually see the blood flowing through the vena cava right next to where you're operating. So that's the plane of dissection that I need right down there. I have to see what's happening up here cranially as well. All right, so it ends right about there. It's kind of hard to tell the deeper extent of the vena cava. Like a millimeter away from the vena cava. A little bit scary. All right, so let's see where the adrenal gland is. Adrenal gland is medial. It's going to come around the front here. The other thing that I'd like to do is isolate the mass completely before I get to the bit that's likely to bleed. Okay, so there's the adrenal gland right there. And is it spontaneously ventilating, or is that the ventilator?
Spontaneously.
Okay. Okay, so there's the adrenal gland sitting right there.
I imagine that's what I'm seeing. Every now and then she has this like respiratory hiccup. Yeah. But I guess it's when she jumps like that. Yeah.
Yeah, and it's probably the cautery that's directly stimulating some muscle.
We're not really trying to think about getting her on the ventilator because that's clearly now I see why it's not her. It's chops. It's chops.
All right, so what I'm going to do is get Aaron to gently retract backward on that. Yep. And then I'm going to try to get a freer elevator in here in between. Try to tease off that adrenal gland. Okay, so that adrenal gland has come off nicely. Okay, so now I've got the left renal vein here. And the renal vein, the vena cava actually is fairly robust. The renal vein, though, is pretty delicate. Okay, so that adrenal gland is pretty free and clear. Can I get cautery turned back up to 20, please? Thank you. Jumpy. Okay. A little bit of saline on our vena cava. So I'm peeling it off the right kidney now. And I really like these to be bloodless surgeries because your visualization is so much better if there's no blood in the way. Also, it means that you haven't cut anything important. So it gives me satisfaction to know also that it's not bleeding, which means I'm probably doing a pretty good job. Be interesting to see what happens farther cranially here. So that's the renal capsule right there. So I can feel it starting to think about maybe releasing a little bit. All right. Let's just try to push some of that liver out of the way. So that's the portal vein up here. Luckily, the portal vein's not attached. So I find the portal vein to be very fragile. Okay. So I'm trying to grab onto that little ligament, hepatic ligament, rather than the liver parenchyma itself, because it's less likely to tear. So I'm trying to get, okay, so I'm in front here. The question is, up here, am I ventral or dorsal to the vena cava? And I think that I'm dorsal to it. So that's pretty loose up there. This is interesting in here. It's very fibrous. Plus the cat's probably going to jump a little bit. It's not a lot out here lateral that you need to be too worried about. Let's just open that up a little bit. So lateral to the kidney, there's really not a lot that's mission critical. Just a little bit more saline, please, on that. It's really not wanting to let go here. It's interesting seeing that blood flowing through there the whole time. The other issue is that the vena cava goes right into the caudate lobe of the liver as well. I'll try to peel it off. Okay, so that's going around the vena cava there. All right. All right, so I've really got to detach it all the way around before I start attacking the vena cava. So that's a so it's starting to think about giving up the ghost a little bit. Grab onto this. So I'm just grabbing onto the connective tissue on the vena cava and see if I can use that to retract a little bit. A bit scary?
A little bit.
All right, so now I'm going to see if I can get up underneath that vena cava. Okay, got a little hole there. We'll just put some pressure on that. Can I get some gel foam, please? No, it'll be Lyostip. Yep. Okay, so I've got a little hole in the vena cava there. No, that's good. Can I get some Hema clips, please?
What size do you want?
Small.
Small, please, Dee.
Okay, so let's go ahead and release that, please.
Yep.
And load that up.
Can I get suction on, please?
And a Yankar tip, maybe?
A little bit? Oh, that's all right.
Maybe use this guy. peel that off.
Take the sheet off.
Yeah. Let's get another little piece of Lyostip, please. So what that tells me is that I'm probably not going to be able to get the vena cava off the mass. So I'm probably going to have to switch to plan B, which is to cut it open and omentalize it. I guess I could take a cuff of mass and leave it with the vena cava. Leave that for now. Okay, so that's patched up nicely. The key in that situation is not to panic, right? There's pretty much always a solution. So what my plan B now is going to be is that I'm going to just take a cuff of capsule and leave it with the vena cava because I'm not able to get underneath that. All right, so what we're going to have to do is incise into the mass, and I am assuming that it's benign, but it almost doesn't matter because if it's a malignant and I'm going to kill the cat getting it out, then it doesn't, rather leave a dirty margin than not have the cat survive the procedure. All right, so let's get that ready, and I'm just going to poke this in here. Okay. And that can go right in if you can get it in there. Okay. That's great. So it looks just like an omental infarct. You can go ahead and pull that out. All right, so now what I can do is I can come alongside the vena cava like this. Much less elegant a solution, but it's going to be effective. Just dislodged our gel foam. The other possibility is to abort the whole procedure, but I don't think we're there yet. You can stitch the vena cava if you need to. The problem is that the wall is so thin that your sutures have a tendency to tear through. So mental infarct is where the omentum loses its blood supply, probably through an infarcted vessel, and causes necrosis. And that kind of pasty white tissue, that's exactly what they look like. And it's what it looked like on CT as well. The other thing is that by suctioning it out, I'm going to release the tension on the capsule as well, which means it might be a little bit easier to dissect around it. And I wouldn't do this if it were a malignancy. Look at that nasty stuff. So basically what I'm doing here is just breaking down all the loculations, and then I'll get an omental pedicle from a healthy bit of omentum and stick it in there. Can we get a little bit of saline, please, on the vena cava? I'm going to grab a thumb forcet, please, and just grab some of that stuff out. Just be careful with the vena cava. Yep. That is nasty. What's that? So I'm going to treat this basically like I would a prostatic abscess, which is to drain it.
Wow.
And then put in omentum.
Yeah. No, I don't think so. No, I think we're pretty good. I think I got a lot of stuff last week and we haven't really been here, so I think we're okay. If there's anything, I can always add it later, I suppose. Or is sending it through now. Yeah. 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 Yeah, that would be awesome. Thank you. I don't know what stuff there is.
Yeah.
Not the suction in there.
Yeah. It's just caseated nastiness. Just trying to decide whether it's worth trying to remove the majority of it or if I'm going to get the same effect by just packing in omentum. I think I'm just going to pack in omentum because there's no risk associated with packing in omentum, whereas if I remove too much and get that vena cava bleeding again, that would be bad. Go ahead and flush in there. That's great, thank you. Let's grab our pool suction tip. Yeah, go ahead and flush inside. Just flush inside the cyst. Yeah, if this were a malignancy, I would have been more aggressive about removing it. As in removing the whole thing. Yeah. I mean, you can do things like create a graft and patch the vena cava. You can put them on bypass. Like, that's probably what they would do in a human. Just put them on cardiopulmonary bypass. And then just resect it and then put in a Dacron graft or something. But I don't have that skill set or the equipment. I really can almost get around the whole thing here. So that's exposed there. Yeah, I am just, discretion is the better part of valor here. So I've got a nice pedicle of omentum here. This cat was showing no clinical signs except for weight loss. All right, so we're just going to tuck that right in there. All right, and then can I get some 4O PDS, please? And hold off on suctioning for now. You can moisten, just we won't suction.
You don't want to suck it out.
Yeah. So all labs were all normal in this cat. So now I'm going to try to suture this, but I have to be careful not to suture into the vena cava. Yeah, sticking a needle into the vena cava, especially when I'm not being careful, would definitely result in tearing it. Can you cut that for me, please?
Which one? Both?
This one? Yeah. All right, so what I'm going to do, I think, is just have Aaron retract on this suture here. So I know that I'm safe on this side, that there's no vena cava over here. So I'm just going to do a simple continuous around the outside here. Okay. Pull it a little tighter, just to give me a little bit of retraction. And then I'm going to switch sides with Aaron and figure out what I'm going to do on the other side. I'll probably suture over the top, like on the other side of the vena cava. I'll switch sides. All right, so we'll just move. So that's common bile duct there. That's vena cava there. So definitely I'm not interested in suturing through the vena cava. No, too risky. So I'm just anchoring it to the outside of that capsule. No, tore through. Just leave that long. Might have you grab onto that. Yeah, great, thank you. Yep, you can let that go now. Yep. Yep. All right. So I'm confident that that's stuck in there pretty well. I'm not going to risk tearing the vena cava, so I think I've done all I can. Just make sure that I'm happy that that's tucked in there well. Yeah, that's in there really well. So it's not going anywhere. All right, so can I get some warm saline, please? Thank you. And do we have some we can submit for histopath? Yeah, yeah.
Fresh stuff for you.
Great. So we'll go ahead and pour that in the bowl. Then I'll get some 2O PDS. Okay, go ahead. That's probably enough saline.
Yeah.
Whenever you tickle the inside of the abdominal wall of cats, they always jump, even when they're anesthetized. Now what I'm going to do is grab my other towel clamps, and I'm just going to give Aaron some handles so that I can see my linea. So lift up on that. So yeah, discretion was definitely the way to go here, because I could easily have lost the cat on the table from trying to remove this in its entirety. And given the most likely diagnosis based on my impression from the CT scan and also the aspirate, suggests that the mass itself is not causing a major problem. It's just that infected nastiness that's going on in there, the necrotic stuff that's inside the cyst or inside that omental infarct that's causing the cat to be unwell. And so by removing the majority of it and then omentalizing it so that it's going to absorb any continued necrotic stuff, I think is going to make the cat feel a lot better. You can see that I'm only suturing the external rectus fascia where I missed the linea. You don't need to suture the internal rectus fascia. That external rectus fascia is the holding layer. And also, if you suture the internal rectus fascia and the peritoneum, you can induce adhesion formation. You can probably release both of those, please, Aaron. And scrub out if you'd like, or you can stay, whatever you like.
Do you want me to pass you some of this gunk and put it in a pot? Yeah.
I've got an FHO coming up next, and I will live stream that one as well.
And you got 5 black sponges.
And you have not had to put it on a ventilator, or have you?
I put it on backup ventilation.
Okay. Yep. Yep. Long?
Long? Good?
Yep. I do not do conjunctival grafts. I leave that to the ophthalmologists. I am happy to do eyelid surgery and enucleations, but anything inside the sclera or the cornea, really the conjunctiva, is not my area. Thank you for the nice comment, TW3ETYB.
Suctional. Yeah. You're happy if I scrub out?
Yes,
Okay.
thanks for your help. That was,
Back in and help you.
yeah, that was special guest Aaron, scrubbed into surgery, leaving the stage. Cindy is away, so Aaron, one of our senior nurses, scrubbed in with me. And if you're happy to wait until I'm finished with the whole surgery, I will go back and review any questions that I haven't answered yet. But since I don't have Cindy here, I have to do the closure myself. So I can't review questions. So LigaSure is about probably $25,000 US. I do have another company, the one that I use, that if you message me directly, my email address is ckuntz1, C-K-U-N-T-Z, the number 1, at mac.com. So just email me directly and I can give you the contact details for the company that sells them. They're probably going to be around $5,000 to $6,000 US. So it is a Chinese company, but I've been using this machine for about 6 months now and I've been really happy with it, and it is substantially cheaper. So if you're interested in that, just email me directly at ckuntz, the number 1, at mac.com. I'm going to India next week to lecture in Indore with Piyush. We have about 3,000 people coming, so it's the largest lecture I'll have ever given in one auditorium. It will be interesting and fun. I'm giving about 10 hours of lecture and then a whole day workshop. Pretty sure they're fully booked out. These little forceps, these are Adson forceps, are my favorites. They're really delicate and very, very precise. And I can very easily, with practice, grab the needle, grab the suture, grab the skin exactly where I want it to get exactly the right bite that I want. Again, these are called Adson thumb forceps. And the way I remember that Adson thumb forceps have fewer teeth is because Adson has fewer letters than Brown Adson. So nearly finished, and I will review all the questions that I haven't answered as soon as I get finished with this intradermal suture pattern. It's not the prettiest closure I've ever done. So my email address is CK for kilo, U for uniform, N for November, T for tango, Z or Z for Zulu, the number 1 at mac.com, which is Mac, Mike Alpha Charlie, mac.com. All right, so I'll just go back and check to see if there are any questions I haven't answered. Just taking my gloves off. The workshop, I think, is fully booked out in India. It was advertised, but I think probably only to Indian vets. So I don't know that there is any availability for that workshop. So somebody's saying they got a quote for $22,000 for LigaSure. So this unit that I'm talking about is probably going to be around $5,000 to $6,000 US dollars. So just looking down here. Hi, Texas. So I don't really worry about the gel foam dislodging. I haven't seen that happen before to my knowledge. I guess it's possible that it has happened, but basically I think that it just adheres with time, and especially given the fact that I sutured the omentum down over the top of it. The purpose of the omentum is to absorb any necrotic material or exudate or anything coming out. Now the pasty white tissue, I could tell from the CT scan, it just had a very typical appearance of an omental infarct, so that's what I'm guessing. And then the gel foam would definitely hold the pressure, even for a larger animal, because the blood pressure is the same regardless of the size of the animal. The only animal that has a higher blood pressure is a giraffe. All other animals have a median or a mean arterial pressure of 90 millimeters of mercury. You can't really LigaSure the wall of the vena cava because the vessel size is too big. So you can LigaSure up to about 7 millimeter vessels. You could stitch the vena cava. It is exciting and stressful. That's the way I look at it. And tap like, and also subscribe if you could. If you're watching this, subscribing is really helpful for me. So anesthetic protocol, we used fentanyl and midazolam as our pre-med, and then induced with alfaxan, and then maintained with isoflurane. Hi Korea, hi Portland, Oregon. For electrosurgery, I use somewhere between 20 and 30 watts. I just use saline on the cautery plate. And yes, I can spare the adrenal gland in this case because I didn't have to remove the mass. Hi Aaron from Virginia. Hi United Arab Emirates, Western New York. Hi Mexico. Hi Michigan. Hi Piyush. Hi Mississippi. Hi California. Going all the way back to the bottom. And hopefully you were able to get that email address. Anyway, thanks a lot for watching, and we will see you again soon. Hopefully I'll be doing an FHO a little bit later on today. Talk to you soon.